We are now onto this session of social determinants of health. We know that factors beyond genetics influence cardiovascular risk for individuals and for whole communities. Where people live, where they're born, where they grow, where they age. This explains much of the disparity in cardiovascular outcomes. And I think that policymakers are becoming much more aware of these issues and how they can influence individual behaviour. So the aim of this session is to discuss, highlight the importance of collaborative solutions across different sectors, how we can engage healthcare providers, policymakers, urban planning experts, the private sector, and the communities themselves to implement solutions to address these health disparities. We'll look at how we can raise awareness and educate people on this topic and identify interventions that can really make a difference. So I want to introduce our expert panel to you. We have Stefan Achenbach, who's immediate past president of the European Society of Cardiology. He's chairman of the Department of Cardiology and professor of medicine at the University of Erlangen in Bavaria in Germany. Welcome to you. We also have, to his left, Mpiko Nseke, who is Professor and Chair of Cardiology at the University of Cape Town, Head of the Cardiac Clinic at the Groote Schuur Hospital, and also Vice President South of the Pan-African Society of Cardiology. So welcome to you. Latifat Okara, welcome. You are the Principal and America's Lead for Health Policy Insights at Economist Impact in Washington, D.C., with a background in microbiology and public health, formerly worked for the World Bank, and now founder of Nom Nom Babies, which is a nutrition company I think you'll tell us more about later, so a wide range of backgrounds there. And we have Wando Oliawalo, who is the founder and chief executive officer of Inspire Health Solutions. This is a global healthcare consulting firm, and you work all around the world providing expertise and support with a background as a leading primary care physician. You're also Chief Health Equity Officer and Senior Vice President of Humana Incorporated. All you guys, I don't know how you fit it all in. It's fantastic, and we're really delighted that you've given up your time to come today to talk about the social determinants of health and how we can address these to improve cardiovascular outcomes. So first of all, I just wanted to make sure that we're all on the same page in terms of what social determinants are, which are the most important ones, how do you define it? Stephen, if you wanted to start, and then I'll ask the others to add in any thoughts they might have.
Well, I think we're all on the same page that there are these incredibly important socioeconomic determinants, but it's very hard to put the finger on what the major contributors are. If you want to group them, maybe it's access on one hand, access to healthcare when you're sick and even before you get sick. It's education and environment. That's how I would group these three, but they're all intertwined. For example, we all know that exercise is healthy. In Germany, the strongest predictor of whether a child will engage in sports is the education level of the parents. So this shows how everything is intertwined, and it's hard to put the finger on the single most important component.
I think you had a little joke with me before about one common phrase that people use to describe what's the biggest social determinant.
Well, yeah, there's this top 10 list of the 10 things to do to avoid socioeconomic risk factors for cardiovascular disease. And number one is don't have poor parents.
Okay, some very useful and valuable advice there. Thank you.
And the number two is don't be poor, and if you're poor, don't be so for very long.
Okay, yeah. Thank you for that. And Pico, I don't know how you can beat that, but in terms of being poor, being born to the wrong parents, what do you want to add about your interpretation of social determinants and how they impact cardiovascular treatment?
Right. First of all, to say thank you very much for the invitation to be here. We're all on the same page, no doubt about it, but I do think that it's very evident that the degree to which each of these components, the impact varies, I would imagine, by geography and where we are. There's absolutely no doubt about it. But in addition to some of the things you spoke about, I think there are environments such as South Africa, I can start there, where history and politics and where you fit into that history and its historical context has a big impact on risk of cardiovascular disease, because in many ways that dictates a lot of where you grow up, your education, likelihood of employment, likelihood that you have one or two parents, likelihood that you have HIV or TB or not, and how all those things might impact on your cardiac status and cardiovascular disease. Yeah.
Thank you. And Latifat, did you want to add anything to that?
Well, yeah. Can you hear me?
Yes,
Okay.
we can.
Yeah, I think, first of all, thank you. I think it's really amazing to be here in a room filled with people who are really passionate about, improving cardiovascular health for everyone. So to add to what my panelists have already said, I would say one of the things when I think about social determinants of health, it's really out of your control. It's really about the conditions in which you are born, the place where you are born, the geography where you grow up. Even, your religion sometimes also has a big role to play when we think about your risk of managing cardiovascular, diseases. And we'll talk about that a little bit later. But also, more importantly, your nutrition as well. And I'm looking forward to shedding more light on the role that nutrition has to play when it comes to the onset and the management of cardiovascular disease.
Thank you. And Wanda, what about you? How do you see this?
Yeah, I would, well, first I'll just say thank you very much for the opportunity to be here and to share with all of you. And I agree with what all of my colleagues have said. I just wanted to double click on something that Mpiko said, because I think it is really important to think about legacies that render people unable to have good cardiovascular health. I'm here and my work is largely done in the United States, but looking at disparities across different populations in the United States. And for those of you who are not familiar, the United States has a very deep legacy of racism and structural racism, particularly through programs like redlining, which you might have heard of, that really set generations of African American, Native American, indigenous folks back for centuries and created a large wealth gap. And what we see in so many of our communities is that the places that were historically redlined and marginalized from economic opportunity, from housing opportunity, are those now that decades and almost a century later are struggling with the worst cardiovascular disease in the United States. So I think it's really important that that legacy is really, really discussed as part of the roots for the problem.
Sure, okay. Well, look, we're going to come on to solutions later, and it'd be really interesting to think about how those solutions need to be tailored for the different groups that you're talking about. But fascinating. And I'm really pleased that we get to give that context and background right up in front. But let me first of all turn to Stefan. I want to talk to you about the European region, just drill down a little bit further about practically how these social determinants play out. Give me a picture of your practice, your patients, and the differences that you see and the outcomes as a result.
Well, with the perspective of the European Society of Cardiology, which I've been fortunate to be involved in for a long time, from a global point of view, we might look like a very homogeneous region of the world, ethnically and also economically. But of course, within Europe, we have no really low income, but we have high income and middle income countries. And if you look at the life expectancy, in the high income countries, it's 81.6 years. In the middle income countries, it's 74.2 years. So that's a tremendous difference in life expectancy. In the high income countries, there are about 5 or 6 countries where cancer mortality is higher now than cardiovascular mortality, which shows how important these determinants are for cardiovascular mortality, and especially if you look at premature cardiovascular mortality. That's people under the age of 70 who die from cardiovascular disease. In females, it's 39% of women dying from cardiovascular disease below the age of 70 in middle-income countries, but only 16% in the high-income countries. And this shows on a country-by-country level how large the differences really are. And we see the very same within countries. Data from Scandinavia, just very briefly, 5 years difference in life expectancy between high and low socioeconomic groups. 1.6 to 2.1 times higher cardiovascular disease risk if you're in a low socioeconomic group. So the differences that we see between countries also exist within the countries.
I'm going to come back to you, but Mpiko, I'm presuming you see exactly the same writ large in South Africa.
Very much so. I mean, it's almost an inverted pyramid, if you want to speak about it that way, where it might be that Stefan's talking about a relatively small proportion of people who are marginalized and poor and where those things are different. Ours is almost an inverted pyramid where it's a very small minority of people who whose outcomes actually are not too dissimilar to what we might see in the global north. And then the bulk of people get their cardiovascular disease almost 10, 15, in some instances 20 years earlier than that very small sector. So yes, I would like to echo that and just point out that it really is a huge population burden issue. Yeah.
I mean, you're both scientists, medics, and I appreciate you deal with is data rather than emotions. But it must be really like heartrending when you see two men or two women of a similar age, but from different backgrounds, and one is not different ages, but one coming in with a heart attack 20 years earlier than the other one, and you can see patently why these different social determinants have played a role.
It is. In fact, I teach medical students, and when we talk about risk factors and social determinants of disease, I have to use an example of a single road. It's a highway. On one side is Constantia, which has one of the highest per capita incomes in the world, maybe even. And then the other is Kailicha, one of the poorest communities on the whole continent, literally divided by a road. Okay, and depending on which side of that road you were born on, this speaks volumes about your life history and the kind of diseases that you might come in, including cardiovascular disease. So very, very real.
I'm going to come to Latifa and to Wando, but if you want to make a point on that
Yes,
point, then
on that point, because you said, it's so frustrating to see, one person coming in 20 years later than the other. It's not just the 20 years later, it's also the 2 weeks later. It's the person who is highly educated and has a highly educated wife who feels some chest pain, and before the infarction actually occurs, the couple goes to see the doctor and prevent the worst, or if the chest pain comes, within a few hours they're in the hospital. While others, less well educated, reluctant, and we heard it this morning, migrant populations who are reluctant to be in contact with the healthcare system, they come 2 weeks after the myocardial infarction and severe heart failure. So there's lots of aspects here, longer term and also short-term differences.
Okay, thank you. Okay, Latifa, what's your take on this so far? Any comments on what you've heard and relating to the work you've done in Nigeria and in Washington and elsewhere?
Yeah, I think I would definitely like to pick on that point that you raised in PICO. But first of all, just to give some background, when I worked at the World Bank, most of my work was really around leading country engagements to improve primary healthcare systems and to strengthen the primary healthcare systems in countries in Africa, in South Asia, and in the Pacific Island regions, and also some in South Africa, in South America. And what I've seen is that cardiovascular disease, it raises a lot of health challenges. It's definitely a health issue on its own, and it presents significant and growing challenges in all these regions that I just mentioned. But what I think it's really important to flag is that they all present unique challenges and also unique opportunities. So in Africa, for instance, when they're struggling with infectious diseases coupled with cardiovascular disease and the burden of NCDs more broadly. And when you think about urbanization that has also been plagued in this region, there is also the burden of, I'll say, the epidemiological transition that has really resulted in high increase in processed foods, which is also an issue on its own. And there is this notion where, like in the African countries, if you are consuming more processed food, people assume that you're rich. It's assumed that, so our local foods and local recipes have all taken a back burner because everyone wants to be like what's going on in the Western world and have completely forgotten our local traditions and recipes. And that has really, increased the risk of cardiovascular disease. But there again is the issue of healthcare access. And so in these countries, like in the high-income countries, you see there's probably better infrastructure. But when you go into the low and middle-income countries, there's an issue of, access to healthcare. The primary healthcare centers are really poorly, I would say the equipments are not there to do testing and all of that. And then there's also the issue of, geographical access and economic access as well. And so that's also an issue on its own. And when you think about the NCD progress monitored by the WHO, those three main targets, which is firstly to reduce the burden of, reduce sodium intake by 20%, only about 20% countries are meeting the target. Very little in lower middle income countries or even in the lower income countries, with some significant progress in high income countries. When you also think about reducing the consumption of trans fats, you'll see that there's a lot of work that still needs to be done in the lower middle income countries. All of them are due to several different factors, which I can hopefully get to later on.
Thank you. Yeah, we'll come on to nutrition as a topic later on. But Wanda, let me bring you in. Lots of different points being made there. Strengthening of the healthcare system, access to diagnostics and treatment. Obviously, you know, what do you think are the big challenges in addressing these social determinants at a system level, and how can healthcare organisations overcome this?
Yeah, I think it's just one thing I wanted to emphasize is that, you know, what the differences between high, middle, and low-income countries is important, but also differences within countries. Because from where I work, I'm a primary care physician, a family physician. From where I work, literally, you know, 17 miles west of my clinic and 17 miles east of my clinic, the life expectancy difference is about 20 years. And so even within a country, within a region, there's still lots of challenges. And I think it's important to, so for example, where I am in the United States, in the southern part of our country, Alabama, Mississippi, our maternal child health outcomes are similar to rural Bangladesh. So, you know, so even though we're high income overall, there are still a lot of differences that create problems. So one thing that I think is really important is that to understand, I love what Stefan said earlier, that, you know, the joke he made about poor parents, but the choices that, someone told me this earlier in my public health career, that the choices that people make are the choices that people have. And so if people don't have the opportunity to get fresh foods, to get access to healthcare facilities, if they don't have the ability to be housed and to have stable housing or to have economic mobility, then they have very limited options, and it's very unlikely that they will break a cycle of intergenerational poverty and intergenerational low education and then break out of that. So some of our work and our challenge here is going to be thinking of how do systems actually help interrupt those cycles and move people up out of the educational kind of level that they're at and economic level that they're at.
Okay, well, we'll come on to solutions in a minute. I just want to quickly mention, Pico, Latifa talked about communicable diseases, infectious diseases, and non-communicable diseases and how they interact. And I think that, how do you see that intersection, particularly in sub-Saharan Africa, where you've got enough on your plate dealing with infectious diseases rather than, having to tackle everything else? And can you expand a little bit on that?
Right. I think earlier in some of the sessions, the issue of multimorbidity came up. In some of them, there was the issue of, or the concept of an epidemiological transition came up. And what I would like to say is that in many of the places we live and work, there isn't an epidemiological transition, really. What you have is still very high burdens of infectious diseases. And what they do really is, A, put people at risk of cardiovascular disease in ways in which we are beginning to understand, and or directly cause heart disease in ways we are beginning to understand. And so, as we think of many of the treatment and care paradigms, if we only think them in terms of cardiovascular disease, what we miss is trying to understand how does infectious disease and how do these other diseases interact with cardiovascular disease? How do the drugs interact? How are things accelerated or decelerated? Until we actually get a full understanding of that, I think we offer a disservice. And at this juncture, I'd like to say that the truth of the matter is many of these people are excluded when we design the trials and the studies that are supposed to provide us the evidence for care. Okay, so we conduct them and we have all this list of exclusion criteria that usually means that most of the people from these communities and countries are excluded, try and produce the evidence, and then bring it back and want us to use it there, and then wonder why we talk about culturally insensitive solutions and or treatments where we actually don't really know the impact. Okay, so yeah, I think it's sort of multi-layered, but important that we think about, and as we address the solutions, that we go back and think differently.
Absolutely, I think that's a key point. And I think you're the director of the Mayosi Collaborative Clinical Trials Unit, so obviously you are trying to introduce clinical trials in these areas, and I'm presuming you're trying to push the boundaries on inclusion criteria or exclusion criteria. I mean, what are the innovative interventions that you're testing, or your novel therapies that you're looking at? What are you able to do in that context of difficulties?
Okay, so the concept of innovation is obviously going to be very different, but I think just the fact that many of the studies we design and perform are in these communities, test interventions for diseases that are highly prevalent in these communities is innovation enough, when for generations these communities have been excluded. So I think that's one aspect of innovation. But two, I mean, there are examples, just a simple one, because sometimes the interventions we test are repurposed drugs. You know, if you take a common condition like atrial fibrillation, I think the whole world would have thought that new agents like novel anticoagulants would make a lot of sense. You don't have to test blood, give them to everybody with atrial fibrillation. I see Alvaro in the audience and others. We just did a 5,000 sort of global study where rheumatic heart disease is quite prevalent, testing whether NOACs versus good old-fashioned vitamin K antagonists for atrial fibrillation in the setting of rheumatic heart disease would work. And we found actually that not only was it safer to use warfarin, but it reduced lives, it saved lives. So, you know, and again, if you exclude these communities from the work that we do and make assumptions that observations that we make elsewhere are applicable to them, then there's a potential for harm.
Okay, thank you. I just want to move on to one other issue, and then I'm going to move back to some solutions. So, Stefan, in terms of your CT, your expertise is in CT scanning. You've done a lot of research into that. But what about access, even in Northern Europe, access to CT scans? I said they're a critical tool for heart disease diagnosis. How are health disparities affecting access to these types of scans in Germany and in Europe, in some of the European countries you talk about that are not as privileged as others?
Well, yeah, even within Germany, and we're talking about cardiac CT, which is a fantastic test for specific conditions, mainly chest pain, find out whether it's coronary artery disease. And then there's another indication if you have risk factors to a certain level, you're not so sure whether you should take a statin or not. That's when a calcium scan can have a decision. And for this very specific purpose, in a sort of purified population of individuals with high cardiovascular risk, there are access problems because it's often out of pocket, and a large part of the German population wouldn't be able to afford it. But this is really a very small problem if you look at the global scale. It's almost what you said, you know, it's like culturally insensitive to say that this issue that we have in this bubble that we live in Western Europe and in North America, where we can use the highest technology to, you know, target this very specific population and improve outcomes a tiny little bit in them, which is relevant for these individuals, no questions. But on a global scale, it would be insensitive to say we have to drop CT machines like a parachute everywhere, and we will solve all problems. Yeah. It's in the context, you know, you cannot simply drop technology in a completely different environment and expect it to do good things.
Wando, do you want to come in on that? I mean, obviously, you've mentioned across the US, entirely different situation in different places. And
absolutely, I think it's great. I think by the time, so I'm, you know, at the primary care level, and so my goal is to prevent someone from having to go to Stefan or to Vico, you know, just trying to prevent them from getting there. And when you think about the ability to have even some of the life-saving or diagnostic technologies that are helpful in saving lives or providing diagnostic information, still those things, there's still wide disparities in who has access to those, even in the highest income places. So I think you're right about thinking that we can't just say that because the technology is good, we want everybody to have it, because it might not still be possible. And even within countries, it's very, very different how people will experience that opportunity.
Okay. Thank you. Look, I want to move on to some other types of solutions. Latif, I know that you want to talk about nutrition and obviously this non-babies company that you've set up. How can we actively promote nutritional awareness and provide healthy recipes for growing families? And how can these interventions help in a wider healthcare system?
Yeah, thank you. I think that's a very good question. Nutrition, I would say, is the cornerstone of public health. I like to say that. Maybe other people will disagree, but maybe I may be partial. But the reason I say that is because we are really what we eat, and everything that goes inside you really manifests in different ways, whether it's health-wise or whether you become like maybe sick or, you know, diagnosed with an ailment. And so when it comes to nutrition awareness, Num Num Babies is really founded on the business model that shows that when you educate mothers, they are able to make a better decision in terms of the nutritional values and preferences for their children. And when children start off with a very healthy nutrition from early onset, it has a role to play in their dietary preferences when they become adults. In some cases, it's true, right? And so many of these countries, like in Nigeria, where I deploy nutrition education for vulnerable population through the primary healthcare center, I use the primary healthcare center to say that the primary healthcare center is really the first point of care for many of the vulnerable population in many countries, in low and middle income countries, and even in lower income countries as well. And so if we're able to integrate nutrition services into the primary healthcare systems in a way that it's accessible to the population, then at least we're confident that we're reaching the people that really needs to get that education. And so integrating nutrition awareness and education in the primary healthcare system, whether it is during antenatal care services, then you're able to get to the mothers when they're still pregnant and then teach them about nutrition. But again, from the work that I've seen, I know that nutrition education is not really enough, because choices really, it depends on what is available to you. So it's good enough that you have the nutrition education, but you also have to be cognizant of the fact that our food systems are somewhat failing us if we're being honest. It's more expensive to get healthy food than it is to get processed foods. And so in many of these countries, like I started in my opening remarks, processed foods have become like the go-to. There's a lot of high intake of sugar, high intake of salt from processed foods. But then again, there is this mindset shift that needs to happen, that processed foods is really bad for you, and we should be eating not for taste, not only for taste, but only for the nourishment of your body. So when you think about how can we get to the population, it's really educating them through the primary healthcare centers. That's where you really get them the most. But again, think about access as well.
Sure, okay, thank you for that. Wando, I know that you've been doing educational initiatives in different sectors of different groups. I wondered if you wanted to talk about the intersectionality with gender and race and socioeconomic status and the work that you've been doing with marginalised populations to promote health equity.
Sure, yeah, so, there's a famous story, Dr. Rishi Manchanda, who many of you have probably heard of, who did his TED Talk years ago about the upstreamist doctor, has this illustration that I think you've heard, but there are these people that were looking at a kind of a waterfall, heavy flowing water, and they kept seeing these children that were kind of down drowning at the end of the water, so they would rescue a child and bring them out. Then they would, they'd see more kids coming, they'd go rescue a drowning child and bring them out. And finally someone said, where are these children that are drowning coming from? And they went kind of further upstream and they saw there was someone that was kind of actively throwing this. So they said, well, if we stop that, then we stop them from downstream. And so thinking our orientation around upstream, how do we do it? One thing I've been really excited about that I see as a really great opportunity is lots of health systems are now thinking about, before it was very difficult to get a health system leader or organization, a medical school to even care about social determinants of health and thinking about going upstream. Now you're seeing a lot of health systems across the United States investing in food, and not just here is a meal, but here's how we make sure that you don't have food insecurity. Investing in housing programs, so that because we know that cycle of health that begins with stable housing allows for so much other thing like education, economic mobility. So when we look at the people that are most likely to be in those areas that are serving the most vulnerable populations, the most disenfranchised populations, what we see in our data in the United States is that they tend to be women, and they tend to be people who are considered racial and ethnic minorities. So investing in folks that have that intersectionality, that understand kind of the complexities and the nuances of the people that have been most disenfranchised, has shown to be very promising for our society. So now we know in the United States, only 6% of doctors in the United States are Black or African Americans. So that's not in any way enough to represent the population that is there. So I think back to the point that was made earlier, that teaching people how to provide culturally competent, culturally humble care, and provided in a way that's sensitive to different cultures is important when you don't necessarily have the ability to have everybody, looking the same. So those are kind of things that I think are really important. Emphasizing more women in medicine and public health as much as possible, because those folks tend to provide a different kind of care and look at the holistic nature of people's environments, and then, diversifying the workforce.
Culturally humble medicine, that sounds like a great turn of phrase. And Peggy, do you want to add anything before I come back to Stefan to talk about solutions in the global north? Yeah, what sort of solutions that you want to see to affect change in this area?
Right. No, thanks. That was very important. I think much has been covered. Let me come back to the issue of culturally sensitive care and go back to some of the comments I made earlier about some of the treatment interventions. And again, I'm a hospitalist, I'll speak from this vulnerable population that ends up having missed all the prevention and promotion side of things and are in our hands. Okay, and to say that everybody wants interventions and care that will help them live longer. So it's often not the intervention, in my mind, that is culturally insensitive. It is that we arrive with an intervention and say, here's a solution. Okay, and I think that where we work upstream in a different type of way, where we integrate communities into our research projects, into our trials, such as we do with many of our things. We have community liaisons. We involve them right from the beginning so that they understand what the nature of the problem is, what the type of the solution is, get their input into whether they think it's fine or not, and adjust what we're going to do appropriately. That downstream, when we offer and that care is available, it might end up being the exact same care, but because they've been involved along the entire pathway, that we find that whatever it is that we are proposing is much more acceptable. So again, I think that community participation, community engagement, and being able to have these poor, marginalized people who are so vulnerable to much of what we've been talking about involved in the entire promotion to care pathway, it would be very important.
Yeah, I suppose the kind of people that you're talking about, some of them may be least able to take opportunities to become involved if they are, economically have difficult to find a job. They get a job, and then actually they may not want to be involved in advocacy in the same way that other people are able to, because they don't have a financial background. That's a tricky one. But while you're thinking about that, Stefan, let me come. We've been talking largely about solutions in the global south, in low and middle income countries. What resonates with you, that what you've heard so far, and what are the solutions to attacking these social determinants in Europe?
I think based on what we've heard, we see that we have similar problems on a different scale in high income, middle income, and low income countries. Even in the higher income countries, the socioeconomic factors include, and we have mentioned them a number of times ago, they include education, and education, but also many others, such as social deprivation, loneliness, environmental factors such as noise and air pollution. And since they are socioeconomic factors, it's unfortunately not the doctors or the medical community which can largely change them. We have to work with the politicians, and I really, really enjoyed the discussion about cities today, how cities are much more likely to change something for their population than potentially can be done on a country level. So probably we as doctors have to work intensively to let the population know and let the politicians know, and those who can actually change something, what we think are the most important measures. But I don't think we have good science on which single intervention will have the largest benefit yet. What we can do, however, we've also heard it a number of times, is access. There are numbers of access barriers that we don't even imagine. For us, it's normal to go and see the doctors. But, you know, at least in my country, which is super rich and highly educated, and you have doctors almost more than you have any other profession, there are still parts of the population who are reluctant to go and look for medical care. And language is one major barrier. So on a very small local level, of course, we can try to reach out to those communities who have language and other problems to reach medical care.
Okay, thank you. Look, I want to come on to questions from the audience, so please do stand at the mics and you can ask questions for the panel. Right, we have straight away, we have two. Okay, yes please, your question. Yes please.
Ladies first.
Yes, ladies first.
So thank you. Great panel discussion. Picking up on what Wando said about catching them upstream, I think we should go lower. We should we should look into antenatal care, because the intrauterine environment determines what happens after. So when these women have had poor antenatal care, you know, and then we're talking about, you know, looking after them when they become adults. And it's been shown. We did a study recently in Nigeria. We did a study on peripartum cardiomyopathy, and there was this old belief that it was the birth practices that were pushing the peripartum cardiomyopathy. But what came out from that, you know, study was that the poorer women who didn't have antenatal care, you know, were more likely to come up with with peripartum cardiomyopathy. Thank you.
Latifat, you want, and Wando want to comment. So Latifat first, then Wando.
Yeah, I think I really like that question that you asked. And again, antenatal care is really, I would say, it's an avenue to really get the women because most of the women go to primary health centers for antenatal care. At that moment, you know, we can integrate, you know, treatments or screening services into the antenatal care services, so that as women come into the clinic, we're not only checking like the heartbeat of the baby, we're checking, you know, we're taking BP, we're also educating you about what you need to eat, your salt intake. We're asking you those questions. I mean, the healthcare professionals are asking those critical questions at that level. And we've also seen through research that when mothers really trust their healthcare professionals, they're more likely to go back for subsequent visits, and they're more likely to implement the recommendations from the healthcare professionals, and they take it back home, you know. So I think I just wanted to say that really and truly it starts from that level, at the community level, and then we take it up to the subnational level, to the local levels, and then national levels too.
Thank you.
Yeah, I think that's a fantastic comment, and would love to hear about the study that you referenced. You know, one thing I was going to say is, in my role as a family physician, I get to take care of people from what we call cradle to end of life. And so I actually think that antenatal care starts way before you're even thinking of conceiving or possibly conceiving, and having the opportunity to educate and inform and teach healthy habits and healthy decision-making in the adolescent period, before people are even at the stage where they're going to become pregnant, allows them to make better decisions and be better informed consumers when they get to the stage where that's possible. So I do think that it starts really honestly when children are young, to teach and educate and give them health literacy and all the tools that they need, so that when they get older, they're able to be able to be savvy enough to kind of navigate the system and know what their needs are going to be. So thank you for that comment. I agree entirely.
Thank you. Yes, you can. We've got a question from the panel actually. So hold on one second. That Mpika wants to ask.
Yeah, just to the both of you. It sounds like what you're addressing is healthy mother in a way, but I was just wondering about, you know, nutrition and other aspects that might affect intrauterine growth and what we know about that and its relationship with cardiovascular disease, and if you could comment.
Yeah, I think it's still education in a way. I still go back to that because it's really more about the awareness. And I could speak to antenatal care because that's kind of like the area that I cover when I go to the primary healthcare centers and I interact with mothers. It's really, you know, educating them about the intake, their food intake during pregnancy, and also having that knowledge that even postpartum as well, what they need to consume really affects has a role to play when it comes to the onset of cardiovascular diseases.
Okay. I just want to ask a question to Stefan based on that. In Northern Europe, where you've got more men working from home and more men now taking care of young children, is there a role in Northern Europe for men to be targeted in the same way that you're talking about women targeted in low-income countries.
But as far as antenatal care is concerned, probably not.
But I meant once the babies have just been born.
Yes,
Yeah.
absolutely. I mean,
Postnatal.
we are in a lucky situation. We're in a lucky situation in Europe that men can have, if they choose to do so, to have a larger part in the education of children. And here we go. Education is very important. So of course, men should be equally aware of what is important for their children as women are. I don't think there's a big problem there. I wouldn't think, without having any data, that young men in Europe are less health literate than young women are. I wouldn't think so. You might see a bit more of unresponsible behavior in men, probably across the world, than in women. But these are probably not the men who stay at home and take care of their children anyways. So.
Okay, thank you. Okay, question from the floor. And while he's giving the question, and there's a free microphone down here, so we do have some more time for questions. Okay, so chap at the back, please.
Thank you. I was very interested in listening to the discussion around upstream factors and the environment, but I didn't hear anything about commercial determinants of health. So the tobacco industry, the alcohol industry, fossil fuel, breast milk substitutes, unhealthy diet, and the way they spread misinformation and influence health policies. So I'd be interested to hear what the panel's views are. Thank you.
Thank you. Yeah, good question. The commercial determinants of health, which we haven't mentioned yet. Stefan, do you want to kick off? Who wants to kick off with this?
I will start with one example, is how many decades it took to start having a decent tobacco legislation in Europe is an example of what you just said, the lobby influence of the companies. We're still not where we should be, so this is a clear example.
I can also comment on that, but looking at it from the solutions, what has been done, and I think commercial determinants of health is really important, and I'm really thankful that you brought up that question. I don't know how we didn't talk about that, but I think that's very critical. Tobacco intake, it's a very critical factor or risk factor for the onset of cardiovascular disease. And the example I wanted to bring up is like a country in South America. They've kind of done some, good studies have also shown that there is a lot of work that has been done to increase, smoking cessation, whether it's through increasing taxes or increasing the price of the product, and smoke bans, implementing smoking bans in public places. Even in Brazil, they've done a good amount of work there as well. So I think that has really taken a lot of traction in terms of policy implementation, but there's still a lot of gap and there's still a lot of work that needs to be done. But it's a critical part of the onset of cardiovascular diseases.
Okay. Mando.
Yeah, I'll just add, and thank you for the question. I'll also add that I think back to what I was talking about before, a concept that I speak a lot about placism and where you live, because if you go to some of the wealthier neighborhoods in certain parts of the United States, you don't even see any marketing for tobacco or alcohol at all. Contrast that and go to some of the more urban underserved areas, you are flooded with marketing around alcohol and tobacco. And so I think also that it just goes back to where you have the opportunity to be, and the importance of moving everybody up in socioeconomically, so that you're in that. But I think the lobby against the lobby for tobacco has been pretty strong in the United States. I think we've been very successful. You can't smoke in any restaurants. You can't smoke in many public places without going kind of far from where the event is. But I get back to that thing about talking and educating and empowering people when they're young, so that when they get confronted with these potential the influx of marketing and commercial lobbying, they're hopefully equipped and prepared to make the right decisions.
Yeah, and Pico.
Right, difficult to add to all of that, but I would say, there are two aspects. One is the ratio, for example, of taverns and liquor outlets in poor neighborhoods to clinics relative to more high or wealthy neighborhoods. Alcohol is a huge problem and contributes to excess cardiovascular disease and outcomes. And then the commercial impact in influencing ability to make policy change, because often the same people influence salt content in bread and other things where legislation you find is impossible to shift just because of those kind of interests. So very important question, and yes, it does make a big impact.
Just one brief intervention from Latifat.
Yeah, I also just wanted to say that another thing that we can also do, because one of the purpose of this conference is that we are able to really talk about policy changes that can be implemented, because there's no point talking about the problem if we're not taking the lessons from it and, hopefully having policymakers really make those changes. I think that if we're able to take lessons from other interventions that have worked well, we can implement that, and scale it up in other areas, like in tobacco control, for instance. I live in DC, in the Northwest DC, and when you drive through Northwest, you'll hardly find, people smoking or vaping shops. But when you drive just like 15 minutes down to the Southeast, for instance, in the same DC, you'd find like it's influx of vaping shops and people smoking and drinking. And so it's just, so how do we take those lessons from like sodium control that was done in Argentina to reduce salt by 60% in bread, and that has resulted in reduced incidence of cardiovascular disease? How do we take those lessons into policy change, to make policy changes in countries like in the US, for instance, across different regions and states or cities in the country? So I think that's also important to mention.
Thank you. Okay, just got time for maybe one, maybe two questions, quick questions. Yes, sir.
Yeah, thank you very much. I'm Elijah Gola from Kenya. My question stroke comment is probably to my friend Mpiko, but the other panelists can also comment. There's the issue of the nexus between not just infectious diseases, but maybe deprivation in general, and chronic diseases, cardiovascular diseases, because the sort of paradigm had been that the poorer sections of the population got infectious diseases. As economies developed, those who were in the higher economic status were actually the ones that got non-communicable diseases. But we now know that actually an environment of deprivation, of infection, maternal deprivation that was talked about are actually determinants of future cardiovascular disease. My issue is that I don't think this paradigm is very apparent, not just to policymakers, but even to healthcare workers themselves. So, Pico, what are your thoughts about how do we get the healthcare system to appreciate that deprivation in early life doesn't stop you from getting cardiovascular disease, it actually promotes cardiovascular disease?
We've got 2 minutes left, so
Short question. So, Elijah, my strong belief is that I think the thing that changes policymakers, that allows us to educate our communities, is evidence. If we can be in spaces where we can generate good evidence of these interactions, of that intersection, and its impact on cardiovascular disease, and perhaps interventions that might be able to change that, then I think it'll make a difference. And then, of course, when we have the opportunities in forums like this to highlight that it is a big issue, to write about it, et cetera, et cetera. But at the end of the day, I think I love that talk on air pollution from the morning. I mean, this obviously has been an issue for years and years and years, and now that we are beginning to understand the science and we're beginning to do the studies that are generating the evidence, hopefully we're going to be able to influence policy and practice. And I think really that's the responsibility of the community to do that.
Thank you, Mpiko. Okay, I think just a very quick question, and then we'll have to wrap up. Yeah.
So I'm sorry, there's another question to you, Mpiko. You're a popular man. I loved your point on that innovation, could simply be to broaden the inclusion of patients in trials and, broaden our understanding on the effect of treatments on different population groups. I was wondering what role secondary data sources play in cementing our understanding, right? They, in my opinion, theoretically would be more available or rapidly available to broaden the understanding of treatment effects in underaddressed population, as well as repurpose medications to address existing needs. So are they used, or are there barriers that prevent people from actually using them?
Right.
Thank you.
Thanks. I'll say two things. One about secondary data sources. I assume you mean things like electronic health records. medical aid data. Well, guess who gets excluded from all of that? Right? So we're back to the same problem of access, availability. In most of our world, none of those facilities are available to the poor and marginalized communities for where all this disease burden lies. So lots of hard work ahead. It is possible. We're starting to talk about it, we're starting to think about it. I mean, these kind of things, I mean, the discussion from the session before on cardiovascular, obviously, will hopefully allow us to integrate these kind of things into our cities and then generate the evidence. So it doesn't all have to be trials and formal research, but at present, I don't know about people in other, ELMIC countries, but ours are excluded from secondary data sources.
Okay, thank you for that. Now I'm going to have to bring it to a close. I want to ask each of you in 30 seconds, and I mean 30 seconds, just very briefly, what's the one tangible thing you would like to see changing going forward or adopted to try and address these social determinants or any of these social determinants of health? Stefan?
Excellent education and very strict tobacco laws.
Thank
10
you.
seconds.
That is very, very impressive. That doesn't mean you can take more, you guys. And Pico?
I'll be consistent with what I've been saying the whole time. Include more of these poor and marginalized communities and peoples in the work that we are doing, including, most importantly, research and generating evidence.
Latifa?
I would say implement policy changes using lessons learned from other interventions for everybody.
Thank you. And Wando?
I would say economic and educational empowerment and elevation consistently across the board.
Brilliant. Okay. Well, it's been a fascinating hour. I can't possibly summarize all of that. That's why I asked them to do it in 30 seconds. But I hope that you've got a lot out of that. And thank you to the people for our audience and their questions, because they've been great as well. Thank you, panel. You've been fantastic. Thanks.
Thank you.
Yeah.
Making it easy for us. Thanks.